Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Adoption of Gene Expression Profile Testing and Association with Use of Chemotherapy Among Women with Breast Cancer by Michael J. Hassett et al. My name is Kathleen I. Pritchard, and I am a medical oncologist and senior scientist at the Odette Cancer Center, Sunnybrook Health Sciences Center, and a professor of medicine at the University of Toronto in Toronto, Canada. My oncologic specialty is medical oncology, with specialization in breast cancer and clinical trials. Personalized therapy for breast cancer. Is it really happening? By Kathleen I. Pritchard. This podcast reviews and comments on the use of the National Comprehensive Cancer Network, or NCCN, Breast Cancer Outcomes Database to demonstrate the actual rollout of the use of gene expression profile testing for women with hormone receptor positive, node-negative breast cancer, and the accompanying changes in breast cancer chemotherapy utilization. This fascinating description of the adoption of a tumor-specific gene expression profile, or GEP test, for women with hormone receptor positive, node-negative breast cancer, and the accompanying changes in breast cancer chemotherapy utilization provides considerable food for thought. This paper is a wonderful demonstration of the utility of the National Comprehensive Cancer Network, or NCCN, Breast Cancer Outcome Database, which has prospectively collected patient and tumor characteristics, treatments, and outcome for women with newly diagnosed breast cancer. The database is a comprehensive registry of all breast cancer patients who received their primary care at participating institutions and includes information from a patient survey conducted at first presentation and from regularly scheduled standardized medical record reviews conducted by trained, dedicated clinical research associates. 11 National Cancer Institute designated comprehensive cancer centers and 6 community cancer centers participating in the Michigan Breast Oncology Quality Initiative contributed patients to this analysis. All centers adhered to the same data collection procedures and definitions developed by the NCCN Breast Cancer Outcomes Database. The work in this paper will be only one of many such reports that can be provided from such an excellent, broadly based, and prospectively planned data collection exercise. This paper demonstrates that whether because of or simply accompanying increased use of GEP testing, rates of chemotherapy for low and intermediate risk women in the adjuvant setting have fallen. This downward trend in chemotherapy use is, as the authors point out, a unique and notable shift in patient care in American centers. Has the utilization of chemotherapy decreased because of the results of GEP testing? The answers are not straightforward, as the relationships between GEP testing and chemotherapy use are complex. Patients in the initially NCCN-defined low-risk node-negative groups who received GEP testing were more likely to receive chemotherapy, while those with NCCN-defined high-risk node-negative breast cancer who received GEP testing were less likely to receive chemotherapy than those who did not receive testing. Why? It may be true that those women who are classified as NCCN low risk and for whom physicians or the patients themselves chose GEP testing were women who, for some reason, were selected as not really fitting into the low-risk category. This selection may reflect factors that are not clearly measured, or at least not clearly recorded, but are in some subtle or even subliminal ways identified by patients and or their physicians. Thus, actually doing the testing may have been related to the same concerns that eventually resulted in giving chemotherapy, rather than the test results influencing chemotherapy administration. Whether administration of chemotherapy is actually related to test results has not been studied and cannot be shown in this type of trial. Similarly, those patients at high NCCN risk, for whom physicians or patients themselves felt chemotherapy might not be so likely to be suitable, may have been also more likely to receive GEP testing. Thus, the GEP testing and the lower chemotherapy administration rates may reflect the same underlying reasons, rather than the results of the GEP test influencing chemotherapy administration. Again, this question cannot be clarified from this particular type of study. Furthermore, the decline in overall chemotherapy rates in a broadly based cohort of American patients may be peculiar to the United States, where chemotherapy has been given widely for women at relatively low risk of recurrence in comparison to other North American or Western European countries such as Canada or Great Britain. It would be interesting to study practice pattern changes over the time period in a database in such countries. Other interesting peculiarities emerge. Women who are 50 to 59 years old were more likely to have GEP testing than those under 50 or over 70. Perhaps in the younger patients, a decision to give chemotherapy has already been made, while for those over 70, a decision not to give chemotherapy was already assumed. Again, these data cannot answer that question. The authors also found that women who were better educated and white were more likely to have GEP testing than women who were less well educated and African American. Although the reasons for this are unclear, it suggests yet another situation in which a new, popular, and probably useful test is being incorporated more quickly into the diagnosis and treatment of women with breast cancer who are white and well educated than in those who are African American and less well educated. While good decisions may be able to be made regarding patients without GEP testing, the fact that the better educated white population is more likely to receive it suggests a worrisome disparity of care. Again, it would be interesting to study cohorts such as this in a universal health care scenario such as that of Ontario, where such GEP testing is equally accessible for patients who meet pre-specified criteria in terms of health insurance coverage. We are well aware, however, that access to care can still be disparate depending on social class and education, even in populations where health care is universally financially available. In summary, it is fascinating to see how GEP testing has been incorporated into practice between 2006 and 2008, and how changes in chemotherapy usage have accompanied it. This paper is also of great interest in demonstrating the role of broadly based cohort-type databases and how they can be used to illustrate actual adoption and delivery of recommended health practices. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.